everybody, and welcome to this webinar, which we're going to do today for all of you who want to learn a little bit more about that pesky PIP joint. So let me introduce you to Jacob, who's sitting by my side, who works for Performance Health, and he's going to be my model today, which is fantastic. So he's got one dodgy finger, so I've got to remember to avoid that if possible. You're very welcome to ask questions in the chat, particularly around treatments, options. So let's head down that route rather than the anatomy route, maybe, for the chat, and we'll try and address those towards the end of the webinar. And I'm going to give a really brief overview to what goes wrong in terms of traumatic injuries and when you get swelling and pain around the PIP joint. Now, those of you who know me will know that I actually run a 3-day course on the PIP joint, so 45 minutes, there's only so much we can do. So I've selected a few little bits and pieces to run through why the anatomy of the PIP gets a bit stiff, then how we assess it very briefly, a few bits of that, and then moving on to some treatment modalities. Now, obviously, it's not completely comprehensive, and I've picked a few things that I wanted to focus on, and we'll explore them as we go through. So, of course, with something like a PIP joint, we have to start with anatomy. So, I've drawn you some pictures, and we'll start here with a picture of the ligaments of the PIP joint. Now, these are often injured in sports injuries, ball injuries, where the fingers go in interesting directions. So there are two levels of ligaments. You've got your superficial, the ones near the skin, and you've got your deep ones. So with your deep ligaments, you've got your cord and your accessory collateral, if I'll show you on Jacob's hand here. So this is what gives the lateral, the sideways stability of the PIP joint. So if I wanted to test the cord collateral, then what I'd be doing is putting his finger in around 60 degrees of flexion, and just moving and holding the proximal phalanx absolutely rigid, and I'm moving radially, and I'm moving ulnarly to see whether he would get pain around the lateral borders of the PIP joint. And with the accessory collateral, what we're trying to do is exactly the same, but in extension or just off full extension. And again, with a ligament injury, you will feel pain. You might feel pain in as well. Then you've got your superficial ligaments, your oblique retinacular ligament. That's the one I've drawn there in purple that extends from volar to dorsal. That's a very unusual ligament. It's really involved in that fine control. And your transverse retinacular ligament that comes right across the side of the finger. Now, if we have a look at the flexor tendon anatomy, so running up the front of the hand, in the blue, you've got the flexor digitorum superficialis, and in the middle of the proximal phalanx, then you've got where it splits or bifurcates, which is the formal word for it, and from underneath it comes the flexor digitorum profundus, which pops through the centre. That I've drawn for you in purple, and that extends up into the DIP joint. So one of them, of course, bends the DIP joint, one of them will bend the PIP joint. But you can't test them like that. DIP, yes, I can ask Jacob to just bend the tip. That works nicely. But if I want to test the flexor digitorum superficialis, I can't just bend here because that's also using FDP. So I need to take FDP out and ask him to now bend on his own like that. So we've got a nice FDS there in that finger. So moving on to the volar plate, I've chosen this structure to look at. Again, it gets injured very often, particularly with dorsal dislocations. So this is a very tooth-like structure. At least that's what the shape is like, that sits on the front of the finger. It's actually on the front of all of our joints. We always talk about the volar plate on the PIP joint, but actually don't forget it, it's there on all of the joints. But it's elongated on the PIP, and it's there to try and stop a hyperextension injury, but sometimes, of course, the forces are too much and it will go. If you see a little round bruise and it's painful when you put palpation on directly on the volar portion of the PIP joint, then that's a clue there's a problem with the volar plate. Very gently put a dorsal stretch on the joint. It should come to an end point and it shouldn't be painful. Again, if neither of those are the case, then there may well be a problem with your volar plate. And then let's have a little look at your extensor tendons. So this is way more complicated than the flexors. On the back of the hand, you've got your, what you can see very easily, you've got your extensor digitorum communis running up from the forearm up along the back of the hand. And here it becomes more complex. So we've got the central slip that sits over the top of the PIP joint, your lateral bands that come around the side and insert at the tip. And then, of course, you've got the interplay with the interosseids and the lumbrical muscles. So, and we'll have a look at those. You can see the interosseids muscles, you can see the green structures on your picture, and the lumbricals are the blue picture, the blue muscle on your picture, and they all connect together. Now, if you wanted to assess the PIP ability to extend on its own, then you would need to have some form of a block. So if I pop that underneath there, so it's a bit awkward, up to the end of the proximal phalanx, and I'm going to ask Jacob to actively extend his finger. Okay, so that makes you think, okay, well, the central slip's intact, but actually, if the lateral bands were intact, that would also be able to pull the PIP into extension. So what we actually need to do, again, is push me back against the resistance. Okay, now that would not be possible just with the lateral bands. That's Elson's test, and that would test whether the central slip is actually intact correctly. By the way, thank you. All right. So what happens with swollen joints? You can see here on the presentation, there's a whole heap of different scenarios. Top right-hand corner, this was a PIP joint replacement. Happens to actually be my dad. PIP joint replacement, the one on the bottom right, this is a lady that had a very nasty intra-articular PIP fracture that was held with a Suzuki frame. The frame had just come out. And then you can see a couple of other PIP soft tissue injuries there. So they present quite differently. They might be post-trauma, they might have an intervention. And remember, surgery is a trauma of its own. So why do these joints become such a problem? Well, I've chosen a couple of bits of the anatomy just as a demonstration. But this is not all of it, because every single structure can become involved in the reason why a PIP joint is not able to go through its full range. So if we look on the far left-hand side, we're looking at the dorsal skin. Again, Jacob, your hand, thank you. So on the back of our PIP joints here, we have a lot of excess skin, and that's normal. And in order to flex, that skin needs to be able to elongate as we bend. So it will shorten and it will lengthen. If you've got some swelling underneath the joint, it's the equivalent of putting a pinch. You can all try this yourself. Put a little pinch over the top and hold that skin tight. Now, Jacob, if you try and bend, you can't bend. So you can see that that elongation is required. So something as simple as just swelling, no damage to any joint structure whatsoever, is enough to effectively splint the PIP and prevent it moving very well. If you look in your top right-hand corner, you can see I've drawn you underneath the bones. You can see this little protrusion that is diagrammatically representing the volar plate. In the far left-hand picture, you can see that the joint is in extension and the volar plate is actually beautifully out at length. As the PIP joint heads into flexion, you can see that this volar plate concertinas underneath itself. And the further flexion, the more it concertinas. Now, of course, if that joint is really swollen and painful and it's not really moving and the swelling is turning into that fibrotic tissue, then you can see how the concertina edges of the volar plate actually go to stick together. And that's why you often see PIP joints following a soft tissue injury, or particularly following hyperextension injuries, that will gradually bring themselves into flexion. because the volar plate is just getting tighter and tighter and tighter. And we all know how difficult it is to get back out into extension. And then the last thing I've just highlighted here is the flexor pulley system. When you look in the textbook, you always see the pulley system. It's shown to you with your finger in extension. So we see A1, A2, A3 over the PIP, A4 over middle phalanx, A5. But you can see they'll have cruciate ligaments in between them, and it looks like there are good gaps, which there are in extension. Very rarely in the textbook do you ever see what happens to those pulleys when you flex. And when you flex, all the pulleys actually approximate to each other, and they're one long continuum of a tunnel. So again, if you've got a swollen PIP, DIP joint that naturally falls into flexion, then all of the pulleys are sitting, so A2 touches A3, A3 touches A4, and if you're going to get fibrotic tissue developing, they're going to start to stick together. Yet another reason it's difficult to get back to that full extension. So this is literally a little bit of the PIP anatomy and mechanisms behind stiffness. There's much more. But let's move on and have a look at assessment. The two main things, obviously you need to know about pain, but predominantly you're going to measure edema and range of motion. So let me show you a couple of methods for doing that. So, trust the old tape measure. Really important to get a tape measure that is really narrow. So you need to just smile sweetly at your reps because they're very good at handing these out. What you want to do is circumferentially go around the PIP joint so that you can see clearly where you're sitting. Now, you don't want to pull it so tight that you're making the skin. You shouldn't see any change of colour, but it shouldn't be so loose that it flops around. And by having something that's really mobile and very thin, you're not having to sort of make the diagonal too much, so you're getting it as accurate as you possibly can. So you can see here this sits at about 6.9 centimetres diameter. And a really simple way of doing it is using these lovely ring sizers. Hovercraft, really good. So what you do, start with a large one, just check, okay, that fits nice and easy. That goes further than the PIP, so that's not right. So let me take it down a couple. Okay, again, this goes further than the PIP. It's easy, relatively easy to get across. So I'll just keep going down in sizes until now that feels like a nice fit of the ring over the PIP joint. It actually holds itself there as I wiggle it around. It's not really pinching the skin. It is gliding a little bit, but you know, it's just a little bit on the tight side. I could try. Now I'm having to really help it into place. So as long as you do the same thing in your department as to, you know, are you going to go as far as the hardest you could possibly push? You know, I can push that one on, but I don't want to, particularly not with a sore PIP joint. So all of these have letters on them. This is an X, so I'll be able to it's nice and easy. Then when it comes to goniometers, we need to measure the PIP joint. Now, obviously, you can measure it in isolation, or you can measure it in gross flexion and extension position. That's the standard norm. So I'm going to ask Jacob to extend all of the joints of the finger, and I'm going to just I'm showing under the camera. Now, it's really important. You can see here that Jacob very naturally, it's his natural ability, can go into hyperextension. So it's really important to have a goniometer that allows you to have this hyperextension. So you can see here that actually he's got about 12 degrees of hyperextension in his PIP joint. Now if I ask you to make a fist or concentric fist and keep the thumb out of the way. I'm looking to go absolutely central down the back. So why a see-through splint is really helpful. You can double check your placement. I want to make sure that the arms are absolutely in contact with as much of the proximal phalanx and the middle phalanx as possible. But again, I'm not pushing on anything, it's just where it's comfortably sitting, and you can see I can read this off. In fact, it is dead on 100, okay? So we've got plus 12 to 100 degrees in this joint here. Now, if this was really difficult to get to, of course you can measure it, isolated PIP, but just write down in your notes that that's what you've done, because that's not standard. And the other thing is that as soon as you've got a problem with the PIP joint, it's not uncommon to have a problem with the DIP as well. So it's rare that you'll want to measure one without the other. And it took me a long time to figure out that with these goniometers, this is usually the angle that is recommended that we're using here. And of course, you can use this over a PIP joint and just cut the arms so that they're much shorter. But this angle here is actually super useful for measuring the DIP, because anything with a longer arm will be a bit of a problem because you can't get it in place. Now, I'm probably going to get into big trouble here and say that we are doing our absolute best to get back those goniometers that we all loved with the hinges, the red hinge, the blue hinge. Do you remember those? We are absolutely doing our best to get those back in, because nothing beats those for measuring your DIP joints, because they sit beautifully into the hand. But you can use this filter angle, and because you've got the double scale on the goniometer itself, you actually can measure both this angle and this angle without it being a problem. Thank you very much. Okay, let's move on to a little bit of treatment. So we've measured for swelling. So, okay, let's assume there's a problem with swelling. We've got a variety of options. So Coban is something that we all, or Coflex, or it's called all sorts of things. So let's just use a little bit. Now, there are two ways of using this. So you can have the wider and you can have the narrower. Personally, I prefer using the narrower. I very rarely use the wide unless it's around the proximal end of the hand. But both have been written up, both are perfectly reasonable. So you could use this and you place it around, cut a lot off there, a bit wasteful. Place it around the PIP with a little bit of tension. Actually pinch it together. You have to have a patient that trusts you. Yeah. And then you'll cut it away like so. And then it sits on. Okay, and actually that's seen even with lots of movement. On the whole, it will stay. It will work really well as long as you pinched it together well enough. However, I am apart. I actually like using the wrap-on technique, because I think this works by being on, but also by being put on, if that makes sense. Start distally, because not only is it working to compress, but I'm also helping the swelling move proximally. So I'm wrapping, overlapping, and then it sticks to itself. And again, you can move. Now, you do not need to put tension on the Coban. I think this is a mistake that we all make, and it's a mistake that our patients make as well. Because as you move, the finger bulks up inside, so it's providing its own internal tension. So please advise people, and try it yourself, put it on yourself and see what it's like. Even if you put a 20% stretch on Coban, you will actually find it becomes a bit uncomfortable, and you may lose some sensation or get a change of hold at the tip, and you certainly couldn't wear it overnight if you put any tension on it. So I tell my patients not to worry about taking it on and off all the time, because it works by being on and it works by being put on, because it's always giving that distal to proximal change. Kinesiology tape, I don't know what I would do without it these days. So this works really nicely for the PIP joint for swelling, sitting over the top of the finger. So you're going to cut a piece that is approximately the length from the level of the web space up to the DIP joint, and then you're going to curve the edges. And then you're going to actually, these are my scissors, these are my splitting scissors, and these are my K-tip scissors. You're going to cut along the length, having folded it over, and I'm making almost like a Chinese lantern here. Then I'm going to tear down the middle. You can see me on there. And I'm going to roll this back. So you're always trying to apply kinesiology tape without touching the glue. And then I'm going to try and attach this onto the centre of the finger with a little bit of gapping over the top. About a 15% stretch. 10%, 15% stretch. And place it down. Now, the idea with kinesiology tape for edema is that it is trying to make sure that as you move, it lifts the skin up. So it's increasing the interstitial space to allow the lymphatics to work. Now, obviously, if I was working the lymphatics further down my hand, then I wouldn't have both ends sealed. I'd be doing my lovely sort of octopus legs across maybe the back of the hand. But I find on the finger that those come off so easily that I actually really like to keep it sealed at both ends. So just give that a move, see what it feels like. All right?
Those you do.
Marvelous. Now, the last thing, of course, to think about is a bit of compression. Now, of course, we can use an edema glove. However, if you have an isolated PIP swollen, are you really going to go with a whole edema glove? Probably not. You can make some out of lycra, and make the equivalent out of lycra, but just to show you, in case it is the PIPs are all swollen, or it's global swelling everywhere, but the PIPs are a problem, I'll just show you how these fit. Now, Jacob's not got a small, says politely.
It's a nice way of saying
A
it.
nice way of saying it, but actually this is a medium. So it's quite surprising,
I'm very surprised when it's actually fit.
but it does fit his hand. So they come up really quite big. So don't be surprised that most of the time you'll be using extra small, and medium. Very unlikely that you're going to need to go much bigger than that. But what you're looking for is a fit that gives a lovely smooth compression. And you shouldn't really be able to pinch out much material. It should, otherwise it's not really giving that compression. They do feel really nice on. So again, it can be more acceptable. I've chosen the ones with the open fingers just because it's much more functional. And why not? Kinesiology tape and edema. Okay, lovely. So we're going to have a little look at, you can pop all that off if you want. We're going to have a little look at different ways to gain motion. So we're going to use exercises and splinting. And let me show you. So here are a few edema management pictures. And again, you can see that one with the pink kinesiology tape on the thumb. Actually, you can see that has open ends. That's what I was talking about. They tend to just come away so quickly. I do prefer this sealed option. So let's have a look at some range of movement exercises. I've got a few videos for you. So the first one is just to show you that a lot of people, if they have globally swollen hands, or even just PIP joint is swollen, their natural exercise will be to go from full extension to full flexion. This is never going to get the best results for it. So what we want to do is to teach people to do isolated DRP, isolated PIP, then start using your tendon gliding style by intrinsic minus, intrinsic plus, and then wrap it all up. And people are just amazed. I think you're a genius when you just get them to systematically exercise in the session, and you will immediately gain more flexion. So if I show you this video, Chris, is that right? It's very lovely. So you can see in this video that you've got me blocking for a patient to teach him how to give a lovely, long, sustained pull for the PIPs, for the DRPs to start with, then the PIPs, then I'll take my finger out of the way after that, and then they'll be able to do the two joints together without me getting in the way. And I'm just then encouraging the DRP to curl around over the top of me. So you just need to teach people that technique, what I often get them to do is to think about a finger at a time. So the first time they're exercising, if they're doing, when they get to doing the combined movements, they're moving everything together, but really think about the index finger. The next time, really think about the middle finger, and so on. And then the fifth one, you're doing them all together. And it's really, you'll be amazed how easier it is for them to just focus on one. It's very confusing, particularly when there's differential pain and differential swelling. Let's have a look at the second video, Chris, if that's okay. So this is, in fact, that lady with the intra-articular fracture, which she's got a malalignment. So you can see that orange Coban is on there in order to try and get a realignment, which we did actually manage to gain 20 degrees in fact of change by having all her exercise that way. But you'll also see what I did was added in a bit of a sponge between the fingers. And this often really, really helps with that motion. So all you need are these lovely sponges, and you can cut them into pieces. And when you place them between the fingers, I've only got two there. In fact, what I quite often do is put yellow in here, and then I'll put a pink on the radial side of the hand is often a bit stronger in here. And now if you try and make a fist with them in, it's actually a really nice feeling, and it helps if people who are a bit stiff. It's a really nice way of gaining some flexion. It's also, of course, a good way of gaining ab and abduction. So if you do, that's it. In a minute, I'm quite often put an elastic band around the outside. So they've got resisted abduction, resisted adduction. And I'm glad to say that these are now the original proper, because it was so annoying, was it? We couldn't get these for so long. And I was told that it was because there was a quality control problem, and I wasn't sure I believed them until I bought them from somewhere else. And this is one from somewhere else, and you can see actually the quality was a bit rubbish. So they were telling the truth, but the real ones without the damage and with the consistent yellow, pink, blue, green resistances are back in stock, which is really nice. Okay, another exercise which you're going to find with things like the SAM regime, short arc motion regime. So this might be for a central slip injury, it might be for a PIP. You're going to want to restrict movement. So you can see this one here, which was the PIP replacement. You can see I've restricted the extension with the purple splint, I've restricted the flexion with the blue splint. And then the one that people get in a people with is isolated PIP extension. So I will always teach my patients that it's this, your unaffected hand underneath and block behind here. And now if you just flex the fingers, and now if you just try and straighten that joint on its own, this is giving you resistance. It's there. Now I don't know why, but people just end up all over the place.
Make a big line multiple times.
There you go, exactly. And again, so this is a really lovely exercise to do. And as we know, the central slip is actually not a strong muscle. We never open our hands with force, do we? So they don't have to be strong muscles. Regaining flexion is relatively straightforward. Regaining extension is difficult. So you need to teach this isolated extension exercise and use a splint in the day to block that. And I'm going to make one in a minute so you can see. You want to block that movement. Now, these days they're called relative motion splints. It's nothing new. We've been doing it for years. They've just got a new name where you're blocking one movement to produce another. So we'll do that in a second. So I'm just going to put, I've just pre-cut a bit of easy form, and I'm going to put this into my very lovely new smart splint pan. Now, the really amazing thing with this is I preset this to say I'm putting on in easy form, and I told it what thickness, and I'm going to press a button at the top, and it's now going to count down for how long it takes, so I can carry on treating. And it will beep at me when the material is hot enough, which is great. So while it's doing that, I wouldn't normally with a patient jump from flexion to extension to flexion to extension, apart from an end of treatment. There you go, 10
10
seconds to
second
go.
countdown.
So, teaching someone to do a full passive flexion. This is something that is really difficult for people to gain that control. So they'll either do this or they'll wobble or they'll bounce. Really important to teach people to come in to their gentle, comfortable end of rating, not pushing through pain, but then they're doing a long, sustained holding, not bouncing. So that's something you really need to teach someone to do. Right, let's make this relative motion split. Now, when I'm making these, to be honest, in real rather than on film, I would use a heat gun to heat because dry heat is so much better for sealing this, but I decided that would be too noisy. So we've gone wet heat. So can I lift you up a little bit? No. So if I were, let's do it because I'm on this side of Jacob. Well, let's imagine that we're doing this to block the little and ring fingers. So I'm going to come over the back of the hand. I'm going to pop this between in the third web space, over the back through the first web space here, onto the back, try and get a relatively good seal. And now I can concentrate on here. Now, somewhere that this gets a bit annoying is it rubs. So I just take the opportunity while it's still warm to just roll back the material there. And then slightly curve it over the back of the fingers. And I first you down. And I'm going to move Jacob into flexion. So that what happens is it will have a little bit of bounce in it, and that's normal. What will happen is every time he opens his hand to do something, to wave, to shake hands with someone, to reach around a drink, anything like that, then the MCP will be blocked from fully extending, and it means that he will, as he opens his hand, get that isolated extension. So that works super well. So we just let that go off, and yeah, it's actually really warm in the room. It's going to take a while to go off. But you can, thank you, there we go. So you can see how easy that was to make. I literally just cut a 1 centimetre wide strip of easy form. And I do find these things probably the best of the materials with this one. If you trap a tiny bit of water in there, it's the least likely to pull apart. It has a tiny amount of shrinkage as it goes from hot to cold, but not as much as some of the other ones. So anything that's circumferential, you want to always be a little bit careful around the shrinkage side. Okay, I think that's cold enough. We can pull this off. And so there we have the splint. Now, occasionally I'll heat gun in here just to smooth those edges off, but actually, remarkably, often you don't really need to because it's not that uncomfortable. So we'll let that go off. And you can also see where I've rolled it in here. Again, I might want to flicken that off, but be careful because a tiny bit of heating in the whole thing will just go on you. And these are relatively straightforward for people to wear. So we'll let that go off and then you can try it on again in a moment. So other forms of splinting. Now, very much the easiest way to try and gain, or the best way to try and gain that end of wage extension is to try and think about low prolonged stretch. So we're trying to hold this PIP joint in as much of its comfortable extension for as long as we can, which is obviously overnight. It's going to be the best. There are so many options. Do you go volar? Do you go circumferential? Do you go dorsal? And in fact, I think the next webinar, we're going to look at some dorsally based splints and why you might want to do those instead of others at any time. I've pre-cut these. So again, I've preset this so it knows what I'm doing, which material, yes. That's going in there, I'm beeping that.
So the splint bath is a new splint bath that is coming to the market relatively soon, which is the Rolyan Smart Splint Bath, which comes with a number of presettings on it, which presets your temperature of water and time that you want the thermoplastic in the water floor. They can be adjusted and obviously changed throughout. There's a 10-second warning to give you a little bit of a countdown.
Okay. Ready?
You can pre-register for these or ask us some information that I can get some stuff over to you.
I'm just trialing it for now, so if you really want to know how it is, just ask and I'll let you know. I'm just playing with it. It's got all sorts of, so one of the amazing things for me with this is that I now preset it, so on the days that I come and do clinic, I don't have to come in half an hour early anymore to turn on the splint pan, because it's automatically
Also on
off. You can tell it which day of the week and you can tell it which times. It's absolutely fantastic. And this one also has the ability to have the water filtered, so I can set it up once a day, once a week, whatever I want, to clean through the water itself, which
UV
is
sanitizer.
it's a UV sanitizer, and I've set it up basically to do it in the last 10 minutes of my working day.
Only takes 5 minutes.
It's a 5-minute process, so we'll see how that works, but obviously for the infection control side of things, I think our infection control nursing colleagues are going to be very happy with that. So you can see here I've chosen to go volar with this splint, and I have pre-cut for myself. Oh, I'll tell you my bottle phone. Where did that go? Oh, there it is. I knew it was there somewhere. I knew I was organised. Okay, so I have pre-cut some little rounded edged sticky foot Velcro.
Nicola likes around the edges.
Oh, I like my rounded edges. So I'm not going to go straight across the joint because I don't think that gives such a good fit. I'm going to go diagonal across. Because if I go to the oblique angle, first of all, I've got a bigger area that this is fitting onto. But second of all, I think it fits over the joint a bit better. And if I've got a stiff PIP joint, probably the most important thing I'm going to add to my splint is a little bit of conchal foam that sits here over the PIP. And there you can see that's super comfy. Right,
So much of a difference just with that little bit.
just that little bit holds that joint in place for you. You can just see. Okay, so we want the DIP to be able to freely move. So that's one idea, is to do that. And this is Polyflex 2 I've used here, so really, really moldable. But we could also, so I'm going to put a piece of Aquaplast tea, so I've got red. I'm going to put this in, just tell it that it's Aquaplast. I'm going to tell it that it's Aquaplast 1.6. There we are. And on it goes. It's changed the temperature. Oh, it's gone up. In fact, 76 degrees is the ideal. And of course, we didn't know that with the old spinning pans. We didn't really know. And I used to just leave them in and get chatting and then go back to them later. So this is going to be a good reminder for me. And it's so much quicker. So much quicker.
Heating from, we heated it up yesterday from 16 degrees water to 70 degree water in 25 minutes. And then all of the presets are all manufacturer recommended presets. You can adjust them.
Right. There. Okay, enough about the splint pan. We'll just concentrate on the joint now. So now we've got Aquaplast, and what I've done is I've measured it in terms of how the length of the finger, and I'm going to try and make a circumferential splint. Well, I measured it, but not very well. Huh? So let's. Now, because it's an index finger, it's much nicer to have the seam on the lateral border. So I'm just going to seal it there. But again, you need a patient that trusts you. Now, if I was trying to get a low, prolonged stretch, first of all, I want to allow the DIP to move. So I'm just pulling it underneath here. And then I'm going to ask Jacob to actively extend. I don't want to be putting a massive push. I need to have done all of those treatments before so that he's maximizing his ability to extend. And then, of course, over the hours of night, we know we need at least 6 hours in a row. We're going to be holding the joint in a good extension. By going circumferential, we're actually getting a really good fit around the whole joint, but you might need to, it's so hot in here. You might need to blow on that for me. This was always a problem in COVID, wasn't it? I used to find myself blowing on splints through my mask and realizing how absolutely stupid that was. So just while Jacob does that, this is actually when I've just had a mucus cyst taken off my finger, and it was really swollen, and I just decided I wanted to get the best result I possibly could. Now this is a bit loose for me now, but just after I had that done, I wore this for 3 days, and I didn't put straps on it. I actually taped it on to keep it on. I put a tiny little bit of dressing gauze in between, and literally kept that on for 3 days. And I really could do pretty much everything with it on. Okay, so then what we're going to do is we're going to pop this open. Thank you very much. Good job. Pop this open, and I'm going to just cut away. Now, obviously, when you cut material, you are never going to get such a lovely edge on it. So just try and make your scissor sweeps as long and as clear as you can make them. And then here we have a circumferential splint. We're going to, again, I would normally, if this was going on a patient, I would heat these with a heat gun and then place them on. So just to try and make sure that they don't come away. And put something on here. So now I'm going to go around the middle phalanx, and I'm going to go around the proximal phalanx. I'm going to use Velcro. Pull it in. So you'll see I did actually cut away, probably in total about half a centimetre, maybe just very slightly more. So there's a little bit of give in this. And there we have the second option. Now that's going to feel nice and secure. Okay, so both of them allow the patient a certain amount of flexibility as to what they actually, the amount of force through it. And again, he's got clear DIP option. Okay, so there you go. So you've got a circumferential one, and you've got a volar one as an option as well. And it really is entirely new choice. There is no research that I'm aware of that has compared one to the other. Over what we do know though is that night splinting, that length of time is what really matters at their comfortable end of range. Okay, so two last things I just wanted to show you. And while I do that, I think Jacob's going to just have a little look to see if there are questions. So you've got a variety of different, they used to be called PIP splints. You've got the short, you've got the normal, and you've got the one with coil springs. So when you look in the catalogue, essentially that's the difference. So just to remind you, these two are identical, but one is short and one is long. You will almost always want to use the short, because when you're placing this over the finger, you do not want this, you do not want the DIP to be blocked. And if even in my longest finger, if I was to put that on, my longest finger, well, it's not bad actually. I can still bend my DIP over the end. So, you might need to look at both, but can you see how hard? I don't have hypermobile joints, but it's almost pushing me into a swan neck. So these are very adaptable. If you squeeze them really hard this way, it takes tension off the splint, so that it is easier, putting way less force on. If I hold it like this, let me move those. If I hold it like this before I put it on, now if I put it on, that is way stronger. So just be aware, if you set it for somebody and then they go and put it in their pocket and they go home, they're going to, you know, they may have changed the setting on it. The tempting thing for people is to put these on and have them really strong. Now, because we know the theory of low prolonged stretch, actually having something on for a really prolonged stretch for 10 minutes, is it actually doing anything? It's debatable. It's debatable. So have a think. These ones fit slightly differently because they have that spring in them, obviously, to make the difference there. Okay, so looking at those now, this is as with those splints I just made on Jacob, really looking at gaining extension. The problem we have with PIPs, isn't it, is that it's not only gaining extension, it's also gaining flexion. And the other problem we have is that when you start to make gains in extension, you very often lose in flexion. And then when you have gains in flexion, you lose in extension. So you're playing this constant balancing act. Now, what I would normally say to my patients is during the day, we use our hands far more in a flex position, particularly the ulnar digits. So your daytime is about flexion. That's what we're trying to do. Your nighttime, that long time overnight, if you're lucky, is to try and get that low prolonged stretch. But you can aid it by having at least every time, so if this is going to be huge on me, we'll put it back on Jacob, but you'll see that if I don't have any blocking to my flexion, so I really can work on my flexion during the day, but every time I come to extend, it's going to block me. So you've got that concept during the day, but prioritize the flexion. And at night time, you really want to prioritize the extension in these low prolonged stretch. However, sometimes that very end of range flexion is really difficult to get. So there are these little straps. I did actually fit one to a patient yesterday. We've been doing dynamic splinting to try and increase her flexion after a nasty intra-articular fracture. And it's worked so well, but you know what it's like with a dynamic or static progressive splint into the palm, only got so far. You can't get that very end of range. So you've got these little splits here. They've got the fabrifoam inside them, so they hold onto the finger quite well. But you have to have good flexion for them to actually work. So you slide it over the finger. Can you use the main camera or the little camera?
I can use either.
Go to the little camera.
Yeah.
Go to the little camera, you can see. So you can see over the back here that I've placed this over the finger there. This then, I'm pulling on it, comes round and holds it in. So you can see you could get that end of range, but of course, it only works when you've got a certain amount of DIP flexion. Otherwise, the whole thing, if you don't have good DIP flexion, the whole thing will just fall off. So you have to start with a static progressive splint, and then you can move on to using these final flexion little devices. At least they're nice and convenient. Perfect. So that was a real whiz through challenging PIP joints. Now I've no idea if anybody's got questions. There are
13 questions at the moment.
Okay, we've got some questions, right? So Jacob, if you'd like to.
So starting off, how do you document lack of motion, e.g. flexation deformity to the PIP joint of 30° with neutral not possible and with full flexation to 100° possible? Would you record this as -30° to 100°?
No, I would record it as 30 to 100. So zero, again, if we go to the little camera here, so 0 is straight, fully straight, okay? And then you're gaining movement as you move into flexion. So if I've got somebody who can go from 30, which is what I think you're suggesting here, 30° to 100, I would personally write it 30 over 100. And then I'll know that that's 30 away from straight.
With mine, was it due to the hyper?
So yes, so when I measured Jacob, he went through that 0. So we got 0, here's your angle, down to 100, 110, whatever it is, and that the normal. If somebody then starts coming into hyperextension, that is when you can indicate it, and there is a real debate about whether you count it as a plus or a minus. But that's over the natural motion. So then I would put, so for example, I would, that you're officially meant to put a minus, but I don't like using minus because I think sometimes it just looks like a dash, and the platform memory writing will just put a dash, and then when you go back a month later, you might not remember. So I would then put for Jacob, who was plus 12 over 100. That's how I would record it. But the other thing that's important in terms of recording is that's active. So I would want to look at active range. Then you want to look at, well, what's stopping that 30 degrees? Passively, is it 0? Can I get it to 0 to 100? In which case, this is what we would call an extension lag. So it's an active lag in ability to get straight. Or is it that the joint is stiff, and if I add a passive force to it gently, then I can't get any more? Or I might find I can get it as far as maybe 22 down to 100. And then I would write the active and the passive.
Next one, do you measure the MCPs with a tape for gloves at all?
Do I measure the MCPs with for the glove? Now, interestingly, many of the companies actually suggest measuring around the wrist to get the right size for your edema gloves. And if you're really looking at distal edema, then I find this isn't deeply helpful. I do tend to just try them on until I get the right size, but also always pick a smaller one than you think it's going to be. So, and more often than not, you'll be right, to be fair. And you really are looking for that slight tension. It needs to come right down into the web spaces. But yeah, you can measure it. I'm not entirely sure whether that is completely translatable to the sizes that we're told that they are.
Next one, how does the sponge help with realignment?
Okay, so it wasn't the sponge. So that picture, that video that I showed you, it wasn't the sponge that was helping with the realignment, it was the toe band. So we'll just get some. Now, putting sponges in between the fingers, this is witchcraft. I don't know why it helps. You're just going to have to believe me that it does. And try it with your patients in between each of the fingers. Maybe if I cut that in half again, you'll see I've got one inside each finger here. But if you're struggling to get a hand to fully flex, try it without and try it with. You'll be amazed. But with this particular lady, she had an ulnar malalignment. So we, for the first weeks and weeks and weeks and weeks of her rehab, her fracture, post-fracture rehab, we actually taped the tip of the fingers here so that all of her exercise was done with a radial pull on the tip of the finger. And actually, over time, she never exercised without it. And over time, it just did help realign it.
What does the taping do?
So, kinesiology tape, another one of those miracles that has revolutionized practice. So, kinesiology tape can be used for so many different things. And I'm hoping at some point we might actually just do a whole webinar on taping, but we'll see. The way I used it on Jacob today was using it in a lantern style with about a 15% stretch. The concept there is to lift the skin as he's going through motion. That lifts the skin away and leaves more space underneath the tissues so that the lymphatics can be more effective.
What splint materials are you using?
Good question. So This white one was Polyflex 2, which is actually, to be fair, one of my favourite materials. It is so moldable. But the difference between Polyflex and Polyform, and again, I think you probably will find online, I did a webinar probably a year ago, running through all the features of all the different materials, and that might just help you with identifying which ones are right for you. Polyflex and Polyform are both highly moldable. You saw how it was incredibly flexible in my hands. But the difference between Polyform and Polyflex is, you see on this one, it maintains the ability to be slightly flexible, which means if you've got a swollen joint and it slightly changes, the splint will allow it, or it's slightly swollen, you've got to fit it in, it will allow it in. If you go with Polyform, that is an absolutely fixed material. So once you get it to position, it's rigid. You can't move it at all. So that was Polyflex 2, 1.6. And this is Aquaplast T, and this is the watercolors. It comes in all purple, green, blue, black, multiple colors. And again, this is the 1.6. So for the fingers, particularly because I'm putting a huge amount of contour in, when you get a lot of contour, you only need a very thin material to still. This is absolutely rigid in that plane here, but still quite moldable and flexible circumferentially. So that's what those do. And this one was easy for me. I once had a student who wrote in her thank you card, if you were ever on a desert island and you were allowed one thing, I would suggest you probably choose uniform, which I thought was the funniest thing I've ever seen. But there we go. So this is uniform.
Any advice for splinting for a boutonniere deformity? If tenderness, volar, DIP joint, i.e. cylinder type splint irritates.
Okay, just read that again, slower.
Any advice for splinting for boutonniere deformity?
Yeah, for boutonniere.
That's one. If tenderness, volar, DIPJ, i.e. cylinder type splint irritates.
Okay, so with a boutonniere, you end up with a finger in this sort of position. You can see here, I've just move the system on it. So you can still see my scar tissue. So this is the position you're in. So you need to work on both flexion of the DIP and extension of the PIP. So you're really going to need to have a splint, particularly overnight, that covers the whole thing. So don't just go with the PIP joint. I personally would probably go volar, but my instinct is always volar, and to use a really moldable material. And the nice thing with this is if you've got this position of the finger, you need to have very intricate material to be able to get more extension there and more flexion here. So with this material, you would actually be able to do that. You can make these little nuance of position. And then I would just serial splint it out. If I haven't answered that very well.
In volar got a PIP-J splint, how flexible is the MCP joint? Does it restrict in any way?
No, it doesn't. So you want to make sure that when you put this on, that you might need to you can see that this has rolled a little bit. And I would always just roll it just very slightly underneath here. You want to be able to have, for most things, now there might be some things where you actually do want to restrict. The vast majority of the time, you are going to want to have clear DIP movement and clear MCP movement. And that's one of the reasons these splints are really difficult to do, because you've got such a short space. Jacob, is there a really quick one? Otherwise,
optimal time for leaving the splints on.
Oh yes, good one. Optimal time for leaving the splints on. Go back and read the papers by Celeste Glasgow in 2010 and by Rosemary Prosser in, I wish I could tell you, I can't remember. And then you will see that the ideal is between 6 and 11 hours, although of course you've got the POP option of the 24/7, when those are for the super pesky PIPs that this doesn't work for. Anywhere between 6 and 11 hours, continuous, you don't take it off. Any other questions that are left, they will send them through to me. I will get back to you if I can, although there are hundreds of them.
20.
And oh my goodness, 20 of them. Give me
21.
time. So it's been an absolute pleasure. Thank you for sharing your lunch break with me. I think our next webinar is sometime in June. And thank you very much. Have a lovely rest of the week and enjoy the spring.